All right, my name's Kelly. I've been working at CHI St. Vincent since October of 2018. I am the unit-based educator for the third floor. I cover 3 Northwest, 3 East, and 3 North. So I do all their educational needs on those floors. Then today, we're going to talk about patient experience. So patient experience is important. It provides an excellent patient experience. It's the right thing to do. I mean, we want our patients to have a good experience when they come. It's related to better health outcomes. It's tied to Medicare reimbursements, and we did talk about that in another presentation. It impacts our hospital's reputation. So one thing there, like, we want our patients to have a good experience because when they leave, if they've had a bad experience, how many people do you think they're going to tell? And I always ask, like, do you guys like Starbucks or Dunkin' Donuts? And I usually always have someone say, well, I love Starbucks. Well, I don't. And the reason is my coffee order is always wrong, and my coffee is always cold. So doing that time and time again, I don't like Starbucks for that reason only. So I prefer Dunkin' Donuts. Now I know there's some of you that may love Starbucks as opposed to Dunkin' Donuts. That's because of your experience. So we want people to walk away from CHI St. Vincent and say, that was the best experience. I did not want to be in the hospital, but I had great nurses, I had great patient care techs, the room was clean. We want to make sure that they can say, yeah, I didn't want to be in the hospital, but it was great. So out of all the hospitals to choose from, I want to go there. Make sure if your family member gets sick, you send them to St. Vincent. All right, so a patient perception of their experience. We trust our relatives. So like if since Sarah's working here at St. Vincent, her mom's probably going to say, well, yeah, that's the hospital to go. And if Sandy works here, then her family and her sister and her brother, they're going to say, well, that must be a good place to work. So they're going to come here just because that's where you work. The psychology behind this is just very simple. We want to share our good and our bad experience, so we want to make sure it's a good experience. Satisfied patients tell about their positive experience to 5 other people, so that's just very important because I want to always tell people how great Dunkin' Donuts is. So it's that same principle. During a typical stay in a hospital, a patient may interact with 50 to 60 employees during one day in the hospital. Each of these interactions has an impact on how they feel. So think about that. They're interacting with the nurse, the patient care tech, the chaplain, environmental service, food tray, the dietary food services. When patients see that nurses are in high spirits, they start feeling the same. So as long as you've taken good care of yourself and you're happy and you're rested, even if you've had a bad morning, maybe a bad evening before you come to work, just leave that at the door and just go in and say, I'm going to be taking care of you today. It makes a big difference. All right, so your role in shaping the patient experience. So you all have a role in shaping how the patient feels. Engage with the patient and family. Make sure you introduce yourself and talk to them. Form a strong, trusting relationship and partnership. Apply some of the best practice tactics to shape a positive patient experience. Don't underestimate the power your nursing care has in sharing the patient experience. So if your patient's talking to you about their concern or why they're here, just pause for a second. If you can sit and listen to them. All right. We've talked about this just briefly in another presentation. Care rounding. When you do care rounding, use your AIDIT, bedside report, unit huddles, and patient education. Now we're going to go into more detail on all of these. Care rounding. Okay, so care rounding is when you round on your patient with intentional cause. So what should you use to introduce yourself to the patient? It's something called an AIDIT. So as nurses, we were always trained, you knock on the door, and then you introduce yourself, and then you want to let them know why you're there, the duration. Like knock, knock, and they say, oh, come in. My name's Kelly. I'm going to be your nurse for today. I'm going to take your vitals. It's going to take me about, 10 minutes, 15 minutes. Thank you for letting me care for you. And then you go on about your business. That works for nurses. That works for patient care techs. The chaplains, they should be doing that. I'm Chaplain Smith. I'm going to be in. Can I pray with you? And they're either going to say yes or no. Thank you for letting me care for you. All right, so rounding improves patient satisfaction. It reduces the patient falls, the pressure injuries, and call light use. So how would it improve pressure injury ulcers? So as we round on our patients, the nurses should be rounding on either the odd or the even hour, and the patient care tech should be rounding on the other. So in a 2-hour period, we should be turning our patients. So that's, right there it says every hour from 6 to 2200, and then every 2 hours during the night, and then as needed. Of course, some patients need to be rounded on more often. All right, so hand hygiene. We always want to wash our hands or foam in. Knock and ask permission prior to entering. Eye contact and smile. Acknowledge the patient by their last name. Don't just go in there and say, hey honey, it's me. No. You want to call them by their last name, Mrs. Smith. Introduce yourself. Usually if you just tell them you're the nurse, that's enough. You don't have to tell them I have my master's in nursing. Just tell them you're the nurse. Tell them why you're going to be here, explain the what and the why. And then always thank them. Because they do have a choice. Remember, they don't have to come to this hospital. They can go to another hospital. And we want them to come here. All right, care rounding with purpose. We're going to address the 4 P's: pain, position, proactive toileting, and personal hygiene. We're going to ask them, how is their pain? Are you comfortable? Let me take you to the bathroom. Move the bedside table and personal items so the patient can reach them. And for patient care techs, they may tell you, I'm hurting. If that's fine, just go get the nurse. Let the nurse know. They're hurting. Did they not tell you? Well, this is what they've told me. Then the nurse can give them that pain medicine. If they need to be repositioned, either the nurse or the patient care tech can reposition them. All right, complete any scheduled task as needed. Complete any physician-ordered treatments or procedures. Administer scheduled medications and complete nursing care as needed. All right, when you do your care rounding, visually inspect the room. Note any fall or safety hazards. Clear any clutter, like if we've dropped anything, pick it up off the floor. We don't want anybody to fall. Move the items within reach. Those clear personal belonging trays, they're very inexpensive. They can put their cell phones, their reading glasses, anything that they need that's going to be close by, they can put them right there in that, and then they have their belongings on that bedside table close to them. If they can have water, make sure the water pitcher is close by. Make sure all the safety devices are in place. If they need a fall mat, make sure that's up against the bed like it's supposed to be. And before you leave, ask them, is there anything that you brought to the hospital that you don't have that I can teach you? Maybe they forgot. I mean, most people, when they come to the hospital, they don't always plan on staying. So maybe they need a toothbrush, toothpaste, maybe they need some deodorant, something small. They don't always pack a bag with the intentions of spending the night. Yes.
I was surprised how many people didn't realize that the hospital did have toothpaste and a toothbrush for them if they didn't bring it. They didn't know that we would give that to them, and that surprised me. But yeah, it's true. They would have gone all day without their teeth being brushed if I hadn't had said, right. By the way, I happen to have a toothbrush and toothpaste. And they were surprised, what, you are going to just give that to me? Yes. I'm just going to give that to you.
We're just going to give it to you. We're not going to charge you for it. We're going to give it to you. You use deodorant. And we want to help you get well. And taking a bath and brushing your teeth, that's going to make you feel better. And then you're going to go home and you're going to say, guess what? See, Josh St. Vincent, they gave me a toothbrush and toothpaste because I wasn't planning on spending the night. I wasn't planning on being in the hospital for 5 days. I just thought I had a little cough, but I had the pneumonia. So yeah, great point. And then again, thank you for letting me take care of you. Document at the point of care in the EMR. Sometimes we want to like take their vitals, or we want to take care of them, and then we want to document it later, document it right then. Like for PCTs, when you go in the room, you take their vitals, just document it right then. And that way it's always current, and then the nurse can see it right then. And nurses, there's a lot of tasks that you do, you can do it right there and document it in real time, instead of waiting until you get to the desk and then trying to document it. And then of course someone's gonna ask you for something, and then it's like, I don't know, did I do it, did I not? Just save those few steps and document it in real time. And then when you leave, make sure you wash your hands. All right, bedside shift report. Have you guys all done bedside shift report before? This is one of my favorite things.
I've done it, but it wasn't always on every unit. Do they ask us to do it on every unit here?
They do. They do. They want you to do it on every unit. We started for a period. We did it on every unit. We did it really good. Then we dropped off. Then we did it really good. Then we dropped off. But now we are doing it on every unit. So it is an expectation. And I'm going to tell you why I love it so much. It's a safe handoff, is the responsibility of every nurse and unlicensed personnel. And bedside reports aim to avoid communication failures. There's 3 outcomes to achieve a bedside shift report. Ensure a safe handoff, keeps patients informed about their care, creates trust, and reduces patient anxiety. One thing that I found out is that shift to shift, there's about 70% of information is lost. And I just love getting a bedside shift report, because then I could go in with the night shift nurse. I used to years ago get a report from Sonia, and we would go in and we could look at the patient and I could see, yep, and we would calculate our drips, and I could see they're fine, they're breathing, and it eased me into the shift. And if I had a question that I wasn't sure about, we could step out in the hall and I could ask her about that. And it also involves the patient. So it keeps each nurse accountable. Instead of standing in the hallway or being at the nurse's station, it's like, what? Who is that? What are they talking about? I can see, this is my patient right here. Yes, they do have an IV. I've also gotten a report from another nurse. They're so sweet. He's just the best. His wife's adorable. They have 3 kids and they go to church. But why are they here? Medically, what are we doing? And I would have to pull stuff. Do we have a Foley? She didn't know. What about an IV? What about procedures? It was like pulling stuff. That report took a much longer than doing a bedside shift report with Sonia, because we got the facts, head to toe, and we were back. All right, so these are the top 10 reasons to do bedside shift report. It informs the patient of his next caregiver. So Sonia and I would go in and she would say, this is Kelly, she's going to be taking care of you for the next shift. Accuracy of handoff information. I always got accurate handoff information from Sonia. I was able to lay my eyes on the patient assigned at the beginning of my shift. Because think about it, when do most deaths occur? Normally at that shift. Education, explanation of tubes, lines, drains, and new equipment. Now, I took this from a nursing point of view, because as a new nurse, I could ask, Sonia could explain stuff, and then we could step out and be like, Sonia, let's go over that again. But think about it, what about our patient? The patient also needs to know, what is this? Why do they have the NG tube? Why do they have the chest tube? I could also keep Sonia accountable, and she can keep me accountable. That chest tube's on the spill. Are you going to get me another one? Sure I will. Accountability from one shift to another. Only pertinent information was shared. We didn't gossip about the patient. Sonia would tell me, yes, he's very nice, but we didn't go into where they went to church, because that wasn't pertinent. That didn't matter. All right. It keeps patients informed and included in their care. Where, yes, they've been admitted with pneumonia. They're probably going to go home in about 3 days. It eased me into my shift assignment and responsibility. I never felt like I had to race to all 6 patients and look at them and are they okay? She was able to manage up about me, and I was able to manage up about her, saying nice things about the next coworker coming on. So I can say, this is Sonia, she's going to be your night shift nurse. I've worked with her for quite a while. She's excellent. You don't have to go into this long detail of she has her master's and she's done this. You don't have to set them up, because at the time, I was a new grad. So I didn't want Sonia to say, well, Kelly's been a nurse for 2 weeks now. So, good luck. I wanted her to say something really good, like, Kelly really, is doing great here.
She knows her resources.
Right. That's what I wanted Sonia to say. Yes. Proven practice that enables nurse to accomplish safe handoffs. It's time to stop thinking of why we can't figure out how we can. And also, on this proven practice, I was also better prepared when the doctor made their round, instead of saying, I don't know, I haven't seen the patient yet, I don't know. I could say, well, when we did our bedside shift report, this is what I was told, and if they had any extra questions, I said, well, let's go to the chart and I'll help you with this. Mm-hmm. Instead of the other hospital was like, I was always hit with a question and be like, I don't know. She said he was nice and his wife is super sweet and they go to church, so other than that, I don't know. What do you want to know about their kids? So this is the reason I love bedside shift reports. All right, this is kind of a step-by-step approach. You should go in together, you should use your AIDIT, then you should verify that you have the right patient, look at their name band. Make sure, and then check the second identifier. Use the handoff page in the EMR as a guide. There's a couple of there's one in Cerner, there's a handoff report. I'm seeing other people use something from STAR. It's just kind of like the dietary guide. It has their name, their room number, and their diagnosis. Mm-hmm. And for some reason, some of the nurses are using that, and then they're rewriting it, which I discourage. You should be writing it down one time. Mm-hmm. There's no reason to duplicate and write it 2 or 3 times. And then provide verbal report, perform safety checks and environment. Make sure if I had gone in with Sonia and if the room was bad, I would have called her on it. And after several months, she would have called me on it. It's like, Kelly, why'd you leave this here? I mean, and you can do that very nicely. I even went in with one of the other nurses and she was like, I got an ID in it. And it was a really hard stick, but I got it. And I said, did you need to put the tourniquet on? She said, no. So we took it off. So that was a safety check. We caught it. It was all good. No harm, no foul on that one. And we close with a thank you, and then you can document. There is a place in the electronic medical record in our Cerner to document that you got a handoff from Sonia and what happened.
One of the things I liked about it too was that because it is a 24-hour shift, if things were really rough and I couldn't get to everything, we caught it together, and I could say, I just couldn't get to this, and I could make sure that that was delegated to the next person safely, like they remembered.
Right.
And documented, oh, okay, that dressing, you got to these dressings, but this is the one I need to get done.
Right, instead of just like dumping it.
Yes.
Understand?
Yes.
That is a bad shift. See ya.
Yes.
Yes. And that's what happens when they're so nice, they go to church, they got 3 kids. That's what happens there. Yeah, I was visiting with them and yeah.
Forgot all about it.
I forgot about that. Because they're nice.
Mm-hmm.
All right, so this is an example. This is in your book of how to give a face-to-face handoff bedside shift report. This is something that you could use verbatim. I think if you read this several times and you kind of practice it, it will come very naturally to you. So this is something I'll let you read at home. Okay, so the patient's perspective is valued as being most important. It's not about us. I kind of go back and forth on that. I think it's very much about us, because if we're getting the best information and we're giving the best patient care, then it is going to be totally about the patient. And the patient is going to say, yes, those nurses gave me the best care. Those patients were able to answer all of my questions, always. Those nurses were able to answer my medication questions. And that's something that we could have done, oh, Sonia, did you know he's starting new medication? He's starting his, his Xanax. He's starting this new medication. And then his possible side effects are.
Yeah.
And those are questions that are on those Prescani surveys. So that's something I can tell Sonia, and then he will know also that he's getting this new medication. All right, communicate with patient before bedside shift report starts. Just let them know. We're getting ready to do bedside shift report. So just give us a few minutes and then we'll take care of you. All right, so the off-going nurse can be hands-on and showing oncoming nurse special equipment. All right. If a new diagnosis such as cancer or test results occur, give the information the patient is aware of during bedside shift report. You can give additional information to next shift after bedside shift report. So once in a while, you may find out that the patient's been diagnosed with cancer or some other illness, and maybe they don't know. But you'll know, so you can just let the night shift nurse know, this is the diagnosis, and then go on.
Yeah, physician hasn't had a chance
Yeah.
to discuss yet.
Exactly, physician hasn't notified them yet. Or my all-time there, physicians notified the wife only or the mother only, which sets everyone up for. But yeah, let the nurse know that the patient does not know, and whatever the reason is. Hopefully it's just the physician hasn't had a chance. Discussion with the patient and nursing team the patient's condition, as well as appropriate testing procedures. Check the equipment, supplies, lines, drains in the room. Now, Sonia would always tell me, I've got all your fluids ready for the day. As a new grad, I thought, I don't get that. Well, it only took me like 2 or 3 shifts. Oh, she's got my fluids ready. They were right outside the door, which I'm sure, this has been a long time ago, I'm sure that wasn't right, but that's what she did. We would go in, we would check the fluids. It's like, oh, she's got my fluids ready for me. So she set me up for success. So it didn't take me long to set her up for success, or anyone following after me. So be good to each other. Or like, no, I didn't get your fluids ready because it's been discontinued. Way to go. All right, your patient is off the unit or asleep. What do? Do not wake them unless they've been requested to be awake, but still go in there so that they can at least see that they're breathing, they're resting. Just talk quietly. All right, the oncoming nurse observes patient quietly and performs safety checks. And then later, the oncoming nurse reviews bedside report with patient. Off-going nurse gives verbal report to oncoming nurse if the patient is off the unit, along with estimated time of patient's return to the unit. If visitors are in the room, so explain to them what you're going to do. And then you can say something like this. I always say, make yourself the bad guy. I always suggest, like, why don't you guys go get a cup of coffee? We're going to do our bedside shift report. And then if my patient says, no, I want them here, that's fine. But if you ask the patient, do you want them to stay? You put them in a spot where they can only say yes or no, and they probably really can only say yes, because that's their life or loved one. Because we've all taken care of the man. I was doing his admission history, and he said, now this woman with me, this is my girlfriend, don't tell my wife. So,
In the admission too, you can kind of wait for a private moment to say,
Yes.
when we're giving report, do you want visitors in the room with you, or maybe is there a person you want in the
Right.
room with you?
and that may be their
Their
that
window.
bedside shift report may be their only moment to say anything to the nurse. That may be their only safe
Awkward.
place. Yeah. So you can ask the patient this question. All right, we've covered that. Oh, if the patient is non-compliant, the off-going nurse should say they're uncooperative. So we know how to do that. You can say they were informed to stay in the room, however, they've been down doing whatever, wandering in the gift shop. You don't have to say, anything like that, because we want them to come back, but not in 30 days, remember.
Right.
All right, so bedside shift report is a time for facts, not a time to vent or criticize. All right, before leaving the room, thank the patient for allowing CHI St. Vincent to care for him or her. If oncoming nurse has a question or needs clarification about a sensitive issue, wait until the bedside report and then ask the off-going nurse. Avoid putting a nurse on the spot in front of the patient or family. Just like there are new grads on our floor, we want to take that as a learning opportunity. We don't want to berate them in front of the patient and make them feel like, you mean you didn't know that? We want to do that outside, and then that way they didn't lose face with the patient, but we can teach them. So you guys just beware. There are some new grads. There's even some international nurses. It may be a new skill for them, even though they've nursed for quite a while. All right, so these are benefits of bedside report. It decreases the potential misses and mistakes, keeps patients involved and updated on their plan of care, increases trust for patient with managing up. And you guys are aware with managing up, right? Where we're talking about the next nurse coming on, how good they are. All right, decreases patient waiting at change of shift and feeling forgotten or abandoned. Increases accountability for nurses as they report off in front of the patient. Increases new RN skill level. RN can see and hear what the experienced RN is doing and why. Increases teamwork between shifts. And I just truly believe all that. All right, unit huddle. All right, so at the beginning of your shift, you should be able to kind of come together as a unit and just identify what are the problems, what do we want to resolve for this day, for this night. You want to look back, like what has happened in the past shift. Did a high fall risk, did they fall? If they did, okay, what do we need to do to correct it? You want to anticipate any safety or quality issues in the next shift. Maybe they didn't fall, but maybe you're still thinking they may. Last 5 to 10 minutes occur at the beginning of each shift. So at the very beginning of the shift, and then right before you go home, just kind of gather around like, okay, we made it through the shift. Now, were there any near misses?
I think that's probably one of the best ways to build teamwork too, because the nurses know, oh, we can expect 16 discharges this morning. Yes. Rather than seeing each other running around wondering, am I getting all the discharges? Am I the only one who's getting a discharge? Exactly. You really can paint the picture for how the whole unit is operating.
Yeah, so it's like, okay, I have 6 and I'm going to discharge 5, so I will need help.
Yes.
So
yes.
What does your day look like? Oh, you only have 3 discharges? We're going to be drowning. Can anybody help us? You know, you're right. All right, patient education. We have to educate our patients. Okay, so why is it important to provide effective patient education? It improves quality and safety of care. Discharge education reduces mortality by 10%. It decreases readmissions. And earlier in another presentation, I said we want them to stay home for 30 days or more so we get paid. We want that billing. It increases adherence to recommendations. So as many as 6% of hospital admissions can be linked to non-adherence. It empowers self-care. So if they come in with the pneumonia, they get discharged. We want to make sure they understand what do they need to do to stay well, stay home for those 30 plus days. And we want them to not get it again. What do they need to do? What are some coping skills? Or what are some things to just stay well? And it improves patient satisfaction. The goal is greater than 90% ranking for patient satisfaction. Okay, so this is what our goal of patient education looks like. We assess the needs of their learning. Like where are they at in their disease process? Are there any barriers to learning? Maybe they only speak Spanish. I do not. That's a barrier. Persons being educated. If they only speak Spanish and the spouse speaks English, well, then I have to educate the spouse. Teaching methods. I have to make sure, can they read? If they read, well, they probably only read in Spanish, so I have to find those brochures. Or maybe they're an auditory learner, but I don't speak Spanish. So we have to find how are we going to teach them? What's going to be the best thing? Content and instruction. Like, what are we going to teach them? Are we just going to teach them what is pneumonia? Are we going to teach them what causes pneumonia? I mean, we could go forever on pneumonia, but what do they need to know? And then we want to find out what is the response to our education. And if we don't document our education, it didn't occur. All right, so the first step of patient education is to develop an educational interdisciplinary plan of care. So we may need to get with a team. We may need to find out, well, since I don't speak Spanish, maybe someone else does. Maybe I have a brochure in Spanish on pneumonia, and maybe I have a team member that speaks Spanish. So maybe we can start working together.
Do we have interpreters, interpreter
We
lines?
do. We have a system. It was Marty. It's changed to something else, and it's like an iPad.
It's called Cultura Link. Yeah.
Culture Link.
Yes.
You're right.
Culture Link.
Culture
Oh, I've
Link.
heard of that.
Yes, it's like an iPad, and it's on a stand, and it does sign language, it speaks Spanish, it speaks other languages. So you have to get it from the locked closet because it is expensive, and you take it to the room. So maybe that's what they need. Maybe they need something like that. So some of the key components is patient and family specific. Patient and family should be involved with the plan of care. Because I don't want to just say, well, go home, never get pneumonia again. It has to be specific to them. I can't tell them drink lots of water to reduce the phlegm because maybe they have fluid restrictions. So I have to think about what I'm telling them. Document education every shift. Should change with the changing condition of the patient. Assessment of knowledge deficit or patient education needs should be part of the plan. So we'll chart all of this in our IPOC, and IPOC is what we call plan of care. Okay, so these are some barriers to effective patient education. Health literacy. 50% of our Americans have difficulty with health literacy. 14% of Americans, they can't read. And that's just very sad, and they don't want to admit it either. They are very embarrassed about it. 21% of adults read at a 5th grade level or below. So illiteracy directly costs the healthcare industry $70 million each year. Another barrier is time available for patient education. Patient education begins on admission, but there are some nurses that pneumonia, they should be here for like 3 days, probably max. They shouldn't be here any longer. But if I've had one of those days where I have 5 or 6 patients and I had 5 discharges, I'm not going to realistically have time to take this one patient and start teaching about their discharge. So it should start day 1. We should start planning for them to go home. So that is a barrier, but we have to work on that as a team. And that's where I should be able to say, hey, I need some help. I'm going to be busy with these admits. Could you do some discharge instructions for me? Let them know what their diagnosis is. Inconsistency of information and use of poorly chosen instructional method. So that would be like if they can't read and I'm like, here's your pamphlet. Well, I chose poorly. Or maybe if they can't read, sometimes they'll take it and then they just smile and they won't say they can't read. So if you come back later and ask them what did you read, they may start fessing up. Or they won't have any questions. Yes, ma'am.
So one trick
Yes.
to find out if they can read is when you hand them that pamphlet, hand it to them upside down.
Oh, yes.
See if they turn it around and actually start reading it.
That's a very good trick.
Or have them teach back to you what it says.
Yes. And that's where we're headed real quick. We're getting there. Now, just by explaining all of this to you guys, you're probably only gonna retain about 5% of it. And their favorite words are, nobody told me that. Patients do like to say that. Printed materials, 10% of retention. They have a literacy level about 5th grade is common. I mean, and some patients have a higher literacy level. It's from patient to patient. We do have evidence-based materials in ECRS that you can print out and give to them. 30% retention if they demonstrate it, and if they teach it back to us, that's a 95% retention rate. And then there's a picture, our capture culture link looks a lot like that, only it's a bigger stand right here. But it looks a lot like that. So they gain about 20% if they use an interpreter. Okay, so this is just a recap. You can see, if I told you guys, okay, all you get is the audio, you may retain about 5%. By doing the audio, visual, and the lecture, you may gain 20%. But if I told you all, you have to teach it back to me, you're going to remember 95% of this lecture. All right, so these are our patient education resources. We have electronic medical record discharge instructions. We have CHI toolkits on the Insider. We have ECRS clinical keeper nursing. We have physician consults, so we may have to consult a second provider. We have nursing consults. We have diabetes educators. We have the wound consult, wound ostomy nurses. We have case managers, licensed social workers to help them get set up with home health or an inpatient, outpatient PT, and we have licensed dietitians. So we have lots of resources, so you don't have to do it all. Pull from your resources. So if you're wondering, did you do everything to get them ready to go home? Think about the diagnosis. Do they know what my diagnosis is? The definitions, the symptoms. Do they know why they were diagnosed with that? And then medications. Do they know why they're starting a new medicine? Is it new? Do they know what the side effects are? Do they know to take it with or without food? Equipment. If they're going home with new equipment, it's very important that they do a return demonstration on that. We can't just hand it to them and say, best of luck. Hope you don't come back for 30 days, because that's not going to work. They have to show it to us. Return demonstration on, like, wound care. We have some people that will go home with a wound care back. They need to know how to use that. Do they have activity restrictions? Do they have diet restrictions? If they do, we need to go over that. Make sure they can talk to us about that. And they need to know when to call the doctor. That's probably one of the biggest questions they have is, do I call the doctor when my fever is this? Do I call the doctor for this? Do they have a future appointment? Did it get made?
That's the one that brings them back to the hospital right there, I see.
Yes.
They never make a follow-up appointment if we don't make it for them.
Right. Or made it on a long day. So, but yeah.
Too far down the line, instead of being seen in a week, they won't be seen for 3 weeks.
Yeah, that is a big one. All right, any questions? Yes,
So-
ma'am.
I'm one of those rehires.
Oh, you are? Okay,
Yes.
welcome back. We're so glad
Thank
you're
you.
here with us.
And one thing I wanted to add to the bedside shift report
Yes.
is in Cerner, there's actually an area in the menu that says patient handoff.
There is.
And what's great about it is the fact that if you want to go over labs or anything like that, if you actually pull that up, you've got all of that information right there in front of you.
You do, and I'm encouraging all the nurses on the 3rd floor to move to that instead of the piece of paper they're using.
Yes.
It's double work for them.
Yes.
It is. They're doing such a great job going into the room, introducing themselves, but they need to use that piece of paper. Thank you for bringing that up. Any other questions?
Thank you.